Hi, I'm Phil Owen with Communities for Recovery, and I'm a peer recovery coach for the targeted response team at Communities for Recovery. And today on the show, I have a very special guest, Aaron Ferguson from Community Medical Services. And he is one of my go-to guys in the area for medically assisted treatment. And he has all the know-how, and he's going to drop some knowledge on us today about what's going on with the landscape the way it is. And how are you doing, Aaron?
I'm doing well, Phil. Thanks for having me on. It's a pleasure to join you here. Really
Absolutely.
appreciate
Can you
what you're
tell us a
doing.
little bit about yourself and your agency?
Yeah, so I am a regional impact manager with Community Medical Services. We are a national provider of medications that treat people with opioid use disorder. We have 45 clinics in 9 states now. 3 years ago, we opened the first 24-hour clinic of its kind in the country. So a 24-hour maintenance clinic for people that need treatment for opioid use disorder. And we have integrated pretty heavily with the criminal justice system and work to provide these treatments in jails across the country. I think we're up to about 15 jails right now that we're working with. So my job is primarily in the South. We just started out in Austin, San Antonio, and Williamson County at the beginning of last year. So we've been working to establish our services throughout the region here.
Well, and I know just normally there are enough challenges and barriers that we face with medically assisted treatment and getting people to services and supports and warm handoffs and having a continuity of care and so forth. But I can imagine the climate that we're in now with COVID-19, that it's kind of been a game changer. And I'm curious as to how you guys have adjusted, what challenges and barriers that you've seen, not only in our community, but I know that you guys are in multiple states. So is that varying from state to state? Are there different challenges that are having to be met in each state, or is it, what's the landscape look like and how you're adapting to that?
I think overall we've done really well as a company. We had a lot of measures in place, specifically technologically, to mitigate the in-person issues that would be faced during a pandemic like the one we're facing. So we are already up and running with the capability to do telemedicine for pretty much everything that we could possibly do it for. And we've had to think quickly. Our executive leadership team has really been agile in getting together and developing a protocol that includes 3 steps to implement to minimize person-to-person contact at our clinics. And then we've had a cascade of regulatory changes that I can talk about in a little more detail later that we've had to scramble to keep up with. But for the most part, it seems like we had been operating in a way that was able to respond to something like this. And we've also had a tremendous amount of assistance from our other community partners, organizations that we've developed partnerships with. And I don't know what we would have done without their help.
So I guess the question that I'm dying to ask is, if I'm a person that is wanting to change my opioid use into a safer method of having it managed by a doctor, and I'm looking to get into services, how would I go about it right now?
Share my screen. But I want to be able to show folks kind of the process that we're using. If you'll give me just a second to go ahead and share some of this. So can you see that, Phil?
I sure can.
Okay, so we're currently in level 2 response. So some of the regulations have changed regarding intakes. So, and I can show you the exact regulation itself, but we're actually now able to do telemedicine intakes for buprenorphine. So we're screening people as to whether or not they're at high risk for complications. So a lot of individuals have compromised immune systems and comorbid health conditions such as hepatitis C, COPD, if they're diabetic. We definitely want to screen folks who have any types of risks for complications. And then we're also screening folks for any symptoms that could be related to COVID-19. And based on that screening, we're making a determination as to whether or not they even need to come in person. Now, when it comes to methadone, that in-person requirement is still in place.
Okay.
We're hoping to get some shift on that. But currently, for buprenorphine intakes, we can do those via telemedicine. So the person would be able to meet with the physician on one of the platforms like the one we're using now. And then, if they were screened as low risk for complications and they could make it into the clinic, they would come in. Otherwise, if they were high risk, we'd do everything we can to do a remote intake. And then if it was for methadone, they would come in and do an alternate dispensing where they're not having any physical contact with anyone at the clinic.
Okay.
So take-home medications have been modified per guidance, and I can talk about that a little bit more. The dispensing schedule is being staggered to reduce the number of people in the clinic, and we're modifying the staff schedule to provide critical functions in the clinic without having too many people in one place. But we are still doing intakes. We're going to get people in as quickly as we possibly can if they're ready for treatment. Our 24/7 clinics are continuing to operate on their regular hours and their regular schedule. And we realize that this situation is going to result in an increased demand for treatment, even as the drug
Right.
market is strained and the supply side of the drug market is being strained.
Right. Very good. Well, that certainly helps a bit. So if someone is already in services and their medication is methadone, they're still coming in. I'm assuming that take homes have increased.
Yes, so I'll go ahead and just jump right over here to some of the actual guidance that has been put out by the DEA and SAMSA. Give me just a second to find it here. So this is coming from, if you can see this here, this is coming from SAMSA, and this came out back on the 16th. So they were pretty quick to respond to the situation, and what they said was states may request blanket exceptions for all stable patients in an OTP to receive 28 days of take-home doses of the patient's medication for opioid use disorder. And then states may request up to 14 days for people who are less stable, but who the opioid treatment program believes can safely handle this level of take-home medication. So what this is doing is SAMHSA is saying, look, guys, we want to minimize contact in person as much as possible. And our way of doing that is to say, look, let's give take-home medications to everyone we possibly can. This is actually being rolled out very differently depending on the state, because it is the result of an interaction between the state opioid treatment authority, for which each state has an individual authority, and the medical director of each organization. So, this may look different depending on your individual clinic. But for our clinics, we are trying to give take homes to as many people as is reasonably possible, with the exception of people in their first 30 days who are still being required to come in person. But we're trying to just minimize in-person contact as much as we can per these SAMHSA guidelines. And then I'll go ahead and show this since I already talked about it. The DEA just recently changed some of their requirements regarding telemedicine. Previously, a person had to have an in-person evaluation in order to have an intake for buprenorphine, and this is the guidance itself here saying that that is no longer in place.
Okay. And I guess another question I would have would be, has any funding stepped in to help with this? Or what are there funding gaps? How are they more severe than they were before? Are they better? Is anybody stepping in to help with funding in this situation?
That's something that we're taking a close look at, and ideally we'd be able to use FEMA funds, but I don't know that that's an option for us.
Right.
there's some talk of a little bit of padding coming from the stimulus package for people who are struggling with employment, but we really want to make sure that folks stay plugged into treatment. So my guess is this is going to be a concerted effort on the part of all opioid treatment programs to cooperate and urge the federal government to assist people in receiving their treatment, as this is an essential service. This is a life-saving service, the absence of which would serve to destabilize our society and culture as a whole. So this is something that is an ongoing conversation, and entities are urging the federal government to give us some type of assistance during this time.
Gotcha. Aaron, I also want to touch base on just some MAT general information, but I want you to be able to speak about everything with regards to our current COVID-19 climate. So I want you to go ahead and let me know everything that we need to know about the current climate. And then I want to ask you about some general MAT for like family members and other people that may not know what MAT services are and that sort of thing.
Sure. So I'll just wrap up a little bit of my talk about the regulatory piece here. What I'm showing here is a breakdown of each individual regulatory body and their current guidance and stance on all these individual topics. So, SAMSA, DEA, Medicare, and by the way, Medicare and Medicaid have expanded their services to cover telemedicine, which many folks thought that should happen a long time ago. But
Sure.
that's, one good part of something like this happening is that it sort of forces everybody to get up to technological speed to make treatment more available to folks. Our payers are taking billing for that. As far as the telemedicine intake for methadone, that's something that we're really trying to get. There's no guidance from the DEA, CMS, any of these other organizations. SAMSA has come out and said that they're not in support of it, but that's definitely something that could help us to get the word out and get the treatment out during this time, even as fentanyl is going to become more prevalent. Drug overdose deaths are probably going to spike as well, and people are going to be seeking treatment. Telegroup counseling is being allowed across all regulatory agencies, and I think I'm pretty sure it's either DEA or SAMSA that came out and said, look guys, you can use whatever platform you choose to use, whatever you can do. You go ahead and just have a communication with people that are seeking counseling, group counseling and individual counseling. Right. Even telephonic counseling, which is something that's never been discussed before. And then we have guidance from pretty much everybody on the take-home exceptions, and then the credentialing portion of it. So this is kind of how it stands currently, and this is changing on a daily basis. I'm involved with some folks that are writing a letter to advocate for some changes to the regulations just during COVID-19 so that we can make treatment more available and so that people aren't congregating in large groups at the clinics. But this is kind of where we're at just currently with that.
Right. Well, being a person in recovery myself, it frightens me to think of, when we talk about social distancing, when I was in my addiction, the last thing I would be thinking of is social distancing because of the urgency to maintain my addiction. I'm sure we're seeing some of these issues come in. I would imagine that, that to see people that are symptomatic of COVID-19 and to be out using and it frightens me to think that, but I've got to think that that's probably the truth because I think about my own experience when I was using. So the other thing I'd like to ask you is about the jails. What's going on with the jails right now? Are we getting medication into the jails right now?
We are continuing to work with all the jails that we have established processes with. We've reached out and communicated to them. It's going to continue on as usual in terms of us delivering medications to your facilities. Please let us know any way we can help to ease your processes. Some of them have been slow in replying because I know that they are just scrambling at this point to try and quarantine any positive cases. Right. As you can imagine, a jail or prison is the prime location for just widespread infection of this type of disease.
Right.
And But we are working overtime to ensure that people are continuing to receive their medications, and that we can even use this as an opportunity to expand the conversation around access to these treatments within criminal justice settings. Another part of that is us having to really strengthen our partnership with community-based organizations such as Communities for Recovery, so that when people are being released from these facilities, that they're not being lost into the illicit drug market, or that they're not being left out, as you say, in a state of social isolation.
Right.
Social isolation is so highly correlated with all types of addictive behaviors and mental health conditions. And it's just really important for us at this point to be following up with people regularly who are already in our treatment milieu. I spent most of the morning this morning following up and checking in with people just to make sure that they were okay. We're not just sending people home with medications and saying, see you later. But as far as the criminal justice settings go, it's going to be tough. Everybody's getting hammered because it's harder to go in than it used to be. I don't know of very many people that are going in to those settings or being allowed to go into
Right.
those settings, even as they're being quarantined. So we're just going to have to really maintain communication with these folks as much as we can, and be ready and willing to help them out upon release, get them
Yes.
plugged back into services.
I agree, absolutely. Well, I love that you focused on something positive in this. And when you talk about Medicare and Medicaid paying for telemed services and this sort of thing, because I think it's very important that we look at the positive while we're all self-isolating. Sometimes it's hard to do, and the anxiety can be tremendous. So I definitely love that, and I want to focus some more of that at the end. But one thing I would like for you to touch on, and you've done it so well before when we've talked, is to family members and friends, people that are struggling with opiates or opioid addiction. Can you just let us know why it is a good thing to consider medically assisted treatment, and give us some of the facts around that? Because I know a lot of the family members I've worked with in the past may view it as enabling. And could you just give us some insight into that, and why it's so important to know the numbers, and why it's so good to look at medically assisted treatment as an option?
Sure. And I definitely sympathize with folks who are reluctant, or maybe think that this isn't necessarily the best path for somebody who's struggling with opioids, because I've shared many of those same concerns myself at one time. I've come to revise my position on that because of examining the evidence and then looking at the lived experiences of the people that I've worked with as a counselor. But I became incredibly interested in what is the best way to help people who are struggling with opioids. And the literature and the science shows us, and this has been under the scientific lens for the last 40 to 50 years, it shows us that providing these medications to a population of people who use opioids cuts the death rate in half. We are now currently dealing with a fentanyl saturated market, the likes of which did not exist even 20 years ago, and it has accelerated the death rate. So whenever somebody is out and about procuring illicit substances from the market, they're being exposed to fentanyl on a regular basis now. The drug supply is so full of contaminants that a person rarely knows what the potency is or the constitution is of what they're buying. And then they're also doing that on a completely random schedule. So people go out and they don't know when they're going to be able to get it. And especially with things like COVID-19, that just completely destabilizes a person's access to whatever it is that they're taking. And that creates a lot of disruption. It creates a lot of desperation. It's probably going to create a spike in violence. And what access to these medications does is it places people on a consistent schedule of reinforcement with a substance, the quantity and quality of and potency of which is known, which is always going to be safer. And so we take the harm reduction philosophy that if people stay alive and we start to address their environment and the psychological underpinnings of their problems, that they'll start to get better. And so our first goal of any type of treatment is to keep the individual, the participant, alive, and to stabilize them in their environment so that we can then have an honest conversation about what's the best positive change to make. And that looks different for everyone. People don't tend on average to stay on these medications for long. Most people use them to stave off withdrawal and then sort of move on and do other things. Whereas other people, their other option besides being on a medication for opioid use disorder is to continue playing Russian roulette out there with the illicit drug market.
Right.
So we really are trying to extend a hand of compassion to say, we care that you're sick and we care that you're worried about dying. And we understand the dangerous nature of the market that you're tapping into by buying illegal substances. And we value your life as a human being. And then, once we get the person medically stabilized, we can have a conversation around the psychological components of why it is that they're compulsively using a substance, or why their addictive behavior could be interfering with other aspects of their life. So that's kind of it in a nutshell.
Thank you so much. I was really anticipating having you on the show. So I guess the couple of the things I'd like to ask, and one would be, do you have, looking into the future as we come out of this, do you foresee services changing or just going back to normal? And what do you think the future looks like coming out of this?
Well, I think that there's a couple things that that a crisis does. It brings organizations together who would not generally be cooperative, and so we see organizations walking in lockstep and realizing, look, guys, we have to pull together in order to address this problem. It's bigger than any one of us. This virus doesn't care what your political affiliation is. It doesn't care what your stance on addiction is. It cares little about our individual predilections. And so it's brought people together, I think, in a really important way. And I'm hoping that that can be sustained. And then another side of it is that I think that crisis does tend to weed out the folks who are not maybe in it for the right reasons, or who are not incredibly determined and personally invested and motivated to do this type of work. And conversely, it also highlights the individuals that have a level of personal investment. It actually spotlights the people who are dedicated and committed to trying to help individuals and put the needs of the individuals first. And then on top of that, I think what it's doing is it's creating an opportunity for a conversation around the regulatory systems that could be serving as a hindrance to people gaining access to treatment when they're ready. So, with these medications, we have the most tightly regulated system in the entire world as it relates to a medication. And many of those regulations are not based on research. They're not based on evidence. And many of them are informed by the stigma against people who use drugs. And what it equates to is a series of hoops that people have to jump through in order to access care that make it even more attractive to just continue what they're doing. I've long said that as long as it's easier to buy heroin than it is to get treatment, we'll continue to have a drug poisoning crisis. And so I think what a lot of this is equating to is an opportunity to rethink some of the outdated regulations that have been in place since the 1980s and get up to technological speed, get up to operational speed, with actually being able to address the drug poisoning crisis from an epidemiological standpoint. So, people are dying from COVID-19, people are dying from drug poisoning. And what lessons can we learn from that to be able to make ourselves more responsive and more able to meet the needs of people that are struggling?
Very well said, and 100% on point in my opinion. I can't thank you enough. Aaron Ferguson with Community Medical Services. One last question. If you could create a flavor of ice cream, what would it be?
Oh boy. I'm definitely a peanut butter aficionado. If I could get, and I'm sure this has already been done, but if I could get peanut butter and bacon into an ice cream, I think they'd have me sold.
Yeah, you're speaking my language. Okay, thank you so much. Once again, Aaron Ferguson with Community Medical Services, and I am Phil Owen with Community for Recovery. We thank you so much for tuning in, and until this is over, everybody, stay your ass at home.
And wash your hands and be safe.
Wash your hands. Thank you so much.